Hey y'all, I hope you guys are staying inside, staying safe from the coronavirus. As you know, today our governor issued a stay at home, which will be, I guess, implemented on tomorrow. So make sure if you're going out today that you're staying safe, you're watching your surroundings, and more importantly, keep those hands washed, okay? So let's get back to the reason why we're doing this video, which is to discuss gallbladder, liver, and pancreas disorders. So there are actually three disorders we'll talk about right now. The first one is cholelithiasis. The second one is cholelithiasis, and also acute and chronic cholecystitis. All right. And so each one of those have different presentations, which we'll talk about shortly. So just take good notes and email me with any questions. So let's talk about cholelithiasis first. So cholelithiasis is actually gallstones within the gallbladder or the biliary tract, and it causes acute, excruciating, colicky pain, which has a sudden onset. Now, if the neck of the gallbladder is obstructed, where we have cholelithiasis, then you may see jaundice in this patient and also clay-colored stools. Both of these are very painful to patients, and pain lasts at least 2 to 6 hours with frequent chills, vomiting, and nausea. Acute cholecystitis is actually inflammation of the gallbladder, and chronic cholecystitis is also inflammation of the gallbladder. One is more rapid and the other one is more vague. Chronic cholecystitis actually is hallmark symptom is referred pain from the back to the shoulder. Indigestion may be seen with chronic cholecystitis, along with nausea as well. There are milder symptoms seen between flare ups because the patient usually just bears this, they're used to having it. How are the three of those diagnosed? So, cholecystitis, choledocystitis, acute and chronic. So, we're looking at ultrasound, CAT scan, and also HIDA scans for diagnostic criteria. Also, a couple of labs that we do. We'll do a liver functions test where there is an elevation in the AST and ALT values. The GGT within the liver functions test is also elevated if there's a problem in the common duct. With this lab values, you also see an elevation in bilirubin levels as well, along with an increase in the white blood cell count and along with the SED rate in cholecystitis. And so, how are we treating these problems? Number one, we're going to have the patient intake what we call a low-fat diet, even if they can take in any food. They may not be able to eat anything with the nausea and vomiting, but if they're able to eat, we want them to have a low-fat diet because, as you know, bile breaks down the fat, and we have a problem with the gallbladder, so the body is not able to do that properly. Meds are given to dissolve the gallstones. And if that treatment is not effective, then the patient goes in for diagnostic ERCP. We talked about diagnostic studies in the upper GI, so I won't go back through those. But one of the things really, really important with an ERCP is before ERCP and also EGD, we want to make sure the patient has a gag reflex before we give any food at all. So really important. So, if the low-fat diet restriction doesn't work, medications are not effective, unfortunately, the patient may have to have that gallbladder removed. And as you know, a person can live without a gallbladder, but there are just certain adjustments to diet that they have to make, which is low-fat. So cholecystectomy, removal of the gallbladder. There's two ways the doctors choose to do that, either laparoscopically or what's called an open cholecystectomy. Doctors really love to do the laparoscopic procedure because it's less traumatic and also it results in fewer hospital stays. Open cholecystectomy are more invasive and result in longer hospital stays. So pre-op and post-op teaching, or pre-op. So what we're going to do is before the surgery, 24 hours before or midnight, the patient is going to be NPO. We're also going to talk about pain management strategies along with before the surgery starting some IV fluids. Post-op, these individuals, if it's laparoscopically, they're going to be told to, when they go home, they usually go home the same day of the procedure. So they spend a couple of hours in recovery, and then they have someone drive them home. They're told that they can shower within 24 hours, but just remove the bandages afterwards. For open cholecystectomy, the stay is a little bit more complicated. So these individuals are kept in the hospital probably 1 to 2 days. They're semi-phallus position, and then they may have a JP drain that's present along with a T-tube. If they have a JP drain, we're going to be monitoring that drainage along with drainage from that T-tube. Really, really, really important. If that T-tube is not draining, we need to call the doctor immediately. You always want to see some drainage in that T-tube. Not uncommon with open cholecystectomy for the bowel sounds to be absent or slow the first 1 to 2 days after surgery. So the second day after surgery, if the bowels are still asleep, we just want to make sure that we're repositioning the patient, getting them up as soon as possible to get them moving around. That's not uncommon for bowel sounds to be silent after surgery. Next disorder we'll talk about is hepatitis. Now, I'm not going to sit here and go through all the types of hepatitis, but what I would encourage you to do is in your book on page 698 is your med-surg book. There's a really nice table there that describes the different hepatitis. It'll let you know what the hepatitis is, what the transmission mode is, the incubation period is, and also the signs and symptoms. For testing, what you need to know are the signs and symptoms of each one and how it's caused. I will go through some general teaching in regards to hepatitis as a whole, but I'm not going to go through all 4 here on this slide. So with hepatitis, there is liver cell damage, and it causes what's called a cell-mediated response because it's a virus, all right? There's extensive inflammation of the liver, so it's actually just liver infection. So what happens in hepatitis is you have Kupffer cells that proliferate and enlarge. And so that's inflammation of those liver cells, and it causes an interruption in bile flow. All right. And so depending on the type you have different transmissions and also signs and symptoms. Just a basic overview, hepatitis A and E usually transmitted through the oral and fecal route. A can be transferred through food handlers and customers. E is seen less in developed countries and transmitted through fecal contamination of water. B, C, and D, chronic inflammations. Individuals can be carrier but have no symptoms, and they are able to transmit to others. So in the hospital, we look at hepatitis B, and a lot of you should have gotten that vaccination already, but we have to be careful because that's in the blood and body fluids. B and C is transferred through parental and sexual route. And so C, if the person uses drugs, it might be transferred there as well. B and C are the most serious forms, and they progress to chronic hepatitis, liver cancer, and in some cases death. Signs and symptoms are in your book as well, so you can go through those. But the main thing we want to prevent is viral replication. All right. And I also know about the phases, the prodromal stage, where symptoms may be misdiagnosed as influenza. And then we have the enteric phase, where there's some jaundice seen, and there also may be some bowel seen as well. With all of them, we have a problem with what's called pruritus, which is itching of the skin because of bile salts deposited there. When do we have convalescence time? Is when jaundice begins to disappear, and that might be 2 to 4 months. So how do we diagnose this? This is diagnosed with history and physical. Sometimes we do what's called serologic assays or enzyme-specific antibodies. Chronic hepatitis is determined by a liver biopsy, and we have elevation in liver functions tests, also elevation in the white blood cell count, and also elevation in PTINRs as well. So care or treatment for hepatitis A. For hepatitis A, you want to have the patient rest, avoid alcohol, avoid narcotic use, and in meals, 4 to 6 small meals per day. And then we want to make sure that the person has Zofran for nausea. There is a vaccine available for active immunity. Hepatitis B and C, usually there is a interferon alpha 2A that's able to be given. Antivirals are used in Hep C. We want to make sure this person gets adequate hydration and rest as well. So what are some nursing management that we want to do? We want to make sure that if we're looking at hepatitis B and C, any contacts are made aware and immunized. And then we also want to make sure that with any of the hepatitis that we get a complete drug list. Why do you think that's important? Well, that's important because drugs are metabolized through the liver. And so we want to make sure, number one, that we know what the patient is taking, but also any drugs with alcohol in them. So cough syrups, they shouldn't be taking those. We want to also assess for other comorbidities as well and address any nursing problems that we might see. So altered nutrition, fatigue, and also knowledge deficit. So for altered nutrition, we want to make sure that this person diet is fortified with minerals and also vitamins. Also fatigue, we want to make sure that the individual gets enough rest. And the knowledge deficit, we want to teach about transmission of the disease and also treatment of it. Prevention, how do we prevent it? Hepatitis A, good hand hygiene, so hand washing. And then we want to avoid preparing foods during the infectious periods. Hepatitis B and C, avoid sexual contact, advise close contacts to receive vaccines. And then also avoid sharing razors and needles as well. Or razors, I hope you're not sharing needles. Complications. In some patients, it may progress to what we call acute liver failure, and a transplant is needed. And they also may have ascites as well. So we'll talk about liver transplant at the end of this slide, but for right now, those are some complications that may happen. This leads us into the next disorder, which is cirrhosis of the liver. The leading cause of this is excessive alcohol ingestion, but hepatitis B and C is the second most common cause. There are 3 different types of cirrhosis. So we have portal cirrhosis, biliary cirrhosis, and also cardiac cirrhosis. Portal cirrhosis usually results from alcoholism. And so we can regenerate the liver if the person stops drinking. Also, they have what's called this widespread scar formation risk because of the disease. Biliary cirrhosis usually happens because of biliary obstruction, so cholelithiasis. And also it comes from infections as well. Let's talk a little bit about cardiac cirrhosis. Cardiac cirrhosis usually comes from long-standing severe right-sided heart failure. And so this person will have a problem with portal hypertension, which is extremely high blood pressure, and also edema as well. Signs and symptoms usually progress without symptoms. Subjective, the person's going to complain of feeling very fatigued. Also, they'll complain of headaches, anorexia, and abdominal pain. And then one of the bigger problems is ascites, which limits chest expansion, causing the dyspnea. And so, I said already, we see the person with edema, skin rashes, and then also excessive gas for real. So what are, because of this cardiac cirrhosis, what are we going to see? Leg and foot edema, and also redness of the palms of the hand. And then again, portal hypertension as well, which is really, really high blood pressure. There's also going to be a deficiency in vitamin K, which affects bleeding factors as well. And then also these individuals will have glucose intolerance. So we may still check the blood pressure, blood sugar, but they're not a diabetic. It's just that they have glucose intolerance. Other problems that they may have is enlarged spleen, which is a big risk because of it, or related to infection. Again, I talked about pruritus, which is itching of the skin from calcium or salt deposits within the skin, elevated bilirubin, and then elevation in liver enzymes after 65% of the liver function is gone. So it's really, really huge problem. So how are we treating this cirrhosis of the liver? Here we go. So how are we going to treat it? Number one, we're going to do a liver biopsy. Also, we'll do albumin stores, albumin levels, and we're going to measure the PT-INR, and elevation of that may indicate poor blood clotting factors. There's also going to be what's called an elevated ammonia level. Why do you think that is so? Because the liver is known as a filter, and so sometimes toxins will build up, causing this level to rise. One medication that we give related to the elevated ammonia level is lactulose. And what happens with lactulose is the individual has large excessive bowel movements where they're releasing the toxins from their body. And then after they have a couple of those large BMs, you'll see a marked change in level of consciousness as well. What is the treatment goal for cirrhosis of the liver? We want to stop liver damage and restore function as well, which I said it can be restored, but the person has to stop drinking. Also, we want to manage ascites as well. So we're going to measure the abdominal girth and make sure that's going down, and also management of encephalopathy by giving lactulose. Because individuals who drink a lot have poor nutrition stores, we're going to make sure that they have multivitamins, zinc, and vitamin B1 as well daily. And then Crestrine is given for the pruritus, which is the calcium deposits or salt deposits within the skin. So other complications, esophageal varices. Write that down. Remember it. Really, really, really high risk, and it's a serious problem because of risk for bleeding. And so if you're given diagnosis to care for people, that is going to be a priority. Remember that, okay? Portal congestion and hypertension as well. And then I've already said there's a massive risk for bleeding. And then we're going to treat these varices with vasopressins as well. So if the liver is not able to be restored or regenerated, the person might have to have a liver transplant. Liver transplant is considered with those with progressive advanced disease. but it's done in non-alcoholic. So if we're considering a person for a liver transplant, they go on a list, and one of the for a wait list for this liver, one of the things that is a requirement is that they can't have any drinking, and also they have to be pretty healthy. And these people have to be matched with the liver, and so they go on this list. And once they get the call that the liver is available, they need to go to the hospital right away to have the surgery. Nursing management post-op. JP drains are placed to measure drainage, and then this individual is on cyclosporins for the rest of their life, and they are given immune suppressants, and so they are really compromised during this state because they don't want this liver to reject. They have to have strict infection control practices, and these patients need to be monitored closely. So after surgery, immediately they're in the ICU for a day or two and then transition to a regular floor. The last disorder we'll talk about is disorder of the pancreas. We have acute and chronic pancreatitis. Pancreatitis is usually caused by excessive alcohol consumption, or also can be from a result of biliary tract obstruction, cancer, or the mumps virus. Chronic is usually caused, again, by many years of alcohol consumption. Abdominal pain is a major symptom, and they also have malabsorption, weight loss, constipation, and mild jaundice. And so treatment for acute and chronic flare-up of pancreatitis. If they are in the acute care setting, they're going to be made NPO right away, and we're going to be giving them IV fluids along with Zofran for the nausea and vomiting. One thing you'll see about many of these upper and lower GI problems, classic medications, Zofran, Compazine, and so also Protonix is given, IV Protonix is given as well. And the main goals of treatment, number one, is to stop the nausea and vomiting, and then also get the pain and symptoms controlled. And the individual is counseled about stopping the drinking because that's a major problem. How is pancreatitis diagnosed? We're going to do an ERCP, also an ultrasound, serum amylase, and then also serum bilirubin as well. They're going to, after they're made NPO and they begin to reintroduce foods, we're going to do a low-fat diet and also non-narcotic pain medications, and teach the patient to abstain from alcohol. So that completes your lecture for upper and lower GI. So if you have any questions or concerns, please feel free to reach out to me. I just want to leave you with a couple of topics that will be on your exam, so make sure you go through these. So number one, colonoscopy. We want to make sure with colonoscopy we do teaching of what that entails. Also, individuals who have to have a colostomy bag. We want to make sure that they are adjusting to that. Also, make sure that we are assessing for what's called body disturbed imaging. Signs that a patient may not be adjusting to that is they don't want to look at the bag. They don't want to participate in the care of the colostomy bag. GI bleeds. We want to know priority assessments for that. So the priority assessment is probably going to be vital signs, and then also CBC, looking at the H&H. Also, iron deficiency. Know the age groups that are affected by that in the lifespan. And then we have nephrotic syndrome. Treatment for that. And then CAUTIs, catheter-acquired UTIs. You want to make sure to know how to prevent that as well. Bladder infections, common symptoms. Make sure you are aware of that. Hiatal hernia teaching, patient teaching for that. No lifting, and also weight loss and food restrictions. Causes of urinary incontinence. The three different types. So you have urge, stress, and then also transient or functional. Esophageal varies. I just talked about that, so you want to make sure that you are aware of that. Renal stones, priority care. So pain management and then straining the urine. Diarrhea. There's a huge risk for electrolyte imbalance, and so we want to monitor for that. We want to make sure that we're checking the BMP and CMP. Also, potassium and sodium levels specifically. TURP procedure. You want to be sure that you know what to do before and after. We talked about in class after the TURP procedure. Make sure that we're flushing the prostate for men. Appendicitis. Care for that. And then peritonitis. Just know care for that as well. ERCP. NPO till gag reflexes return. And then also for most GI concerns, you want to make sure that we're resting the GI tract. Medications that you're going to need to know about for this exam. Omeprazole. Know the indications. What's that for? Compazine. Side effects. Zofran. Side effects. Lab values. And also NSAIDs in the cases that we should not use that. Okay? So that is it. Make sure that you study. If you have any questions, please reach out to me. This is Professor Tasha signing off.